So let's begin with some relevant anatomy. Point out a few anatomic relationships that we need to be aware of. So this is a depiction of the sagittal section through the male anatomy. And of course, you can see the bladder here. The bladder opens up to that part of the urethra we call prostatic urethra. We call it prostatic urethra because the prostate gland wraps around this part of the urethra. A lot of different pathologies in the prostate will cause the prostate to swell. When that happens, this part of the urethra generally is collapsed and then present with urinary tract obstructive symptoms, the specifics of which we'll talk about later. Thereafter, the prostatic urethra opens up to the membranous urethra, and then we have the distal urethra, and of course urine exits the urethral meatus here. A few other anatomic relationships we need to be aware of. Prostate gland is in close proximity to the rectal vault. Therefore, a digital rectal exam, you can easily palpate the posterior face of the prostate. You're palpating that part of the prostate, which is called the peripheral zone of the prostate. There are actually several zones in the prostate that are distinguishable by histology. When you palpate the prostate here through a digital rectal exam, you're actually palpating that part of the prostate we call the peripheral zone. Number of different types of pathologies develop in the peripheral zone that you can detect on palpation, one of which is adenocarcinoma of the prostate. It usually develops in the peripheral zone of the prostate, and usually you can palpate it. Okay? It is the textural changes associated with it. Typically, you'll feel a hard, nodular prostate when an adenocarcinoma is developing in the prostate gland. Usually, the prostate has kind of a firm, rubbery texture to it. But when cancer is developing, it becomes hard, it becomes nodular, and again, you can palpate that on a digital rectal exam. Let's take a look at some different types of congenital defects of the penis first. We'll take a look at some common malformations. One of the malformations that we commonly see is called hypospadias. This is a condition where the urethral meatus, instead of opening up on the tip of the glans penis, opens up somewhere along the ventral surface of the penis. It sometimes is a birth defect that occurs in isolation, but in other instances it can be associated with other types of pathology like cryptorchidism, which is a condition where the testicles don't distend into the scrotal sac. We'll talk about that later, but sometimes they do exist. This type of defect does exist in isolation. Here's an example of a hypospadias. You're looking along the ventral surface of the shaft of the penis. Here's the head. Here's the foreskin here, and of course you can see the urethral meatus is open here instead of here. This is a problem that can be corrected surgically. Usually, surgically we can create a lumen here in the urethra, the head of the penis, using some of the scrotal foreskin, and we make a tube, and that will place the urethral meatus in the proper position. Any questions about hypospadias? There is a condition where the urethral meatus opens up along the dorsal surface of the penis. That's called epispadias. Any questions?
If the meatus is not corrected, would it be a problem in the long run, or it wouldn't be? It's just cosmetic.
It depends. It is a cosmetic concern, but there also might be some practical issues associated with it. There might be some stricturing. There might be some. It can be the surgery can be more of a necessity than cosmetic surgery. Anything else? Okay, let's take a look at some inflammatory lesions. We've got balanitis and balanopastitis. Okay, balanitis. Balanitis is a condition where the head of the penis becomes inflamed. Usually this is something that occurs almost exclusively in uncircumcised males. What happens is debris, collectively called smegma, will collect underneath the foreskin and it'll incite inflammation. And this makes the head of the penis very erythematous and tender. Here you can see an example of balanitis. Again, you can notice that the entire head is remarkable inflammation. Again, this is something usually observed in uncircumcised men. The solution to this problem is very simple. You just have to instruct the male in proper hygiene. Generally, circumcised men, partially circumcised men, don't have this problem because debris don't collect underneath the foreskin and irritate the head. And sometimes the inflammation will spread from the head to the foreskin itself. If that's the case, we have a condition called balanopastitis. This is what it looks like, and you can see a young infant male. We have, of course, the scrotum, and you can see the overlying foreskin itself is inflamed. That's called balanopastitis. Questions on that? Okay, let's discuss phimosis and paraphimosis. Phimosis is a condition where the foreskin is strictured. It's strictured in such a way that it's difficult to retract at the head of the penis. If one tries to forcefully retract the foreskin that's strictured over the head of the penis, the foreskin kind of strangles the blood supply to the tip of the penis, and the condition becomes very painful. If left in that position, ischemia can develop in the head of the penis, resulting in some degree of necrosis and scarring. Okay, let's take a look at an example. This is an example of phimosis, and you can clearly see that the foreskin is strictured here distally. This makes it difficult to retract the foreskin over the head. If it's forcefully retracted, it's going to collapse the arterial supply. It's going to be very painful. People like this will complain of painful erections. When they have an erection, sometimes the foreskin will retract, and again, it puts them in that position where they have a restricted blood supply. Sometimes the foreskin is left in a retracted position such that significant ischemia will develop in the head of the penis. If that's the case, then necrosis in the penis develops, and we have a condition called paraphimosis. This is paraphimosis. This was an unfortunate incident in which an unconscious patient involved in a vehicular accident was brought into the trauma bay. One of the standard procedures that we have is to put a Foley catheter in to keep the bladder drained. Whoever put this Foley catheter in didn't realize the patient had phimosis, forcefully retracted the foreskin over the head, left it in that position, put the Foley in, and you can see after a day or two you have considerable degenerative changes here. There's desquamation here, the epidermis is coming off, and also you can see areas of necrosis here. That's called paraphimosis, and it's caused by phimosis. Any questions on phimosis, paraphimosis? Usually, the way we would treat something like phimosis would be to conduct either a partial circumcision or a complete circumcision. This would, of course, remove the whole problem entirely. Okay, neoplasms of the penis. Okay, it's not a terribly common condition. It only makes up 0.25% of all the cancers that we observe in males. Risk factors, majority occur in uncircumcised males. Presumably that's due to, again, accumulation of smegma underneath the foreskin. There is a close association also with HPV. HPV causes cervical cancer in women. It can cause penile cancer in men. Most common are 16, 18, and 31, those are the serotypes. This type of cancer begins like most other types of epithelial cancers, begins as a dysplastic lesion, and it evolves possibly into a locally invasive cancer. These types of cancers are squamous cell carcinomas. They begin as dysplasias. The dysplasias are referred to as Bowen's disease. Bowen's disease. Bowen's disease generally presents as a kind of leukoplakia on the penis. It is no different than cervical dysplasia. It's a type of skin dysplasia. It has the potential for degenerating into locally invasive squamous cell carcinoma. Here's an example of Bowen disease in the penis. And two examples. You can see it presents as leukoplakia. You can see there are white discolorations on the foreskin, on the head. That white discoloration is due to the production of keratin. Keratin is overproduced in these dysplastic areas and it presents as leukoplakia, white discoloration. You'll notice the areas of leukoplakia are surrounded by erythema. That's actually a good sign. It seems that the person's immune system is recognizing the dysplastic cells as being bad and it looks like it's inside an inflammation. That's actually a good sign. Here's another example of Bowen disease. Very common to see Bowen disease around the coronal sulcus. This is where a lot of the cancers tend to develop, so it's also a common place we see this dysplasia. Okay, you can treat this just like you would any other dysplasia. You can obliterate the dysplastic cells, you can remove the dysplastic cells. If you can obliterate the dysplastic cells, naturally you reduce the chance of developing a locally invasive squamous cell carcinoma. If, however, this is not treated, it has the potential for degenerating to locally invasive squamous cell carcinoma. Squamous cell carcinoma can present different ways. It can be kind of a verrucoid looking exophytic mass, meaning it kind of looks like a big wart. In other instances, it can present as an ulcerative lesion. Here's an example of what squamous cell carcinoma looks like. Again, we've got the shaft and the head, and we can see this clean, moist-looking ulcer. This is typical of a squamous cell carcinoma. Again, you notice it tends to develop in the vicinity of the coronal sulcus. This is a common place where dysplasia and cancers will develop. Usually, the ulcer is painless unless it gets secondarily infected. Sometimes an ulcer like this is confused with a Lewitic ulcer. Lewitic means syphilis. There is an easy way to tell the difference. Sometimes history will tell you the difference. The Lewitic ulcers tend to heal over time, whereas the squamous cell carcinomas tend to get worse with time. Another way of telling the difference is take a sample of the debris within the ulcer. If this is a cancer, you can see the atypical cells. If this is a Lewitic ulcer, you should be able to observe the spirochete, troponema pallidum. Okay, let's have a look at some of this histology. First, take a look at Bowen disease. We'll have a look at skin first, give you a quick comparison of what normal looks like. Subsection through normal skin. And again, by this time you recognize the epidermis here. There's the dermis, and you know that there's a basement membrane running through here. It's a natural tissue bearer. We look at this epidermis, you can see it's maturing properly. You've got the stratum basalis where all the cells are crowded together. So that's normal, they're all multiplying. But they move upward, you can see they spread out and they mature. They change their morphology. That's properly maturing epithelium. Bowen disease is essentially a dysplasia. It's a carcinoma in situ. Okay, it has first stages. This is an example of a carcinoma in situ, Bowen's disease. In section through the skin. This is the epidermis. This is the dermis here. And you can see in the epidermis you have a lot of crowded cells, very pleomorphic. So far, they're respecting the basement membrane, but they don't have to do that for very much longer. They can break through that basement membrane. If they mutate, they'll become a squamous cell carcinoma. Now remember, Bowen disease presents with leukoplakia. I pointed out the white discolorations. That's because of the keratin production. The stratum corneum becomes very thick. If you take a look at normal skin in this area, you've got a relatively thin stratum corneum here. But over here, you've got a very thick stratum corneum. Okay, and that extra keratin gives it that look display. Questions on this?
What is the CIS of the penis?
CIS of the penis.
Mhm.
So it's just a form of severe dysplasia.
Okay.
That's severe full thickness dysplasia, that's CIS. Carcinoma in situ.
Oh, that's carcinoma in situ.
CIS, carcinoma in situ.
Okay, and then, so what do you mean that is a solitary plaque on the penis shaft? Is that the leukoplakia that we were talking about? But what does it mean that
That's
it's solitary?
leuko means white, plaquey, so it's a solitary white plaque, it could appear that way.
Solitary because it's like isolated or?
It can be an isolated patch. Again, the most likely area would be in the coronal sulcus. Of course, you can have multiple patches, it could be elsewhere. But that's a common presentation. Scrotum, okay, problems with scrotum, squamous cell carcinoma of the scrotum, don't see too much of that. It is, interestingly enough, it's an occupationally associated disease. The people who typically will develop squamous cell carcinoma of the scrotum are chimney sweepers. And the hypothesis is that chimney sweepers are being exposed to toxins like dioxins. And when they sweat, sweat drags all of the dioxins down and essentially deposits them in the lowest, one of the lower areas, which would be the scrotum. And so the dioxins concentrate there and cause dysplasias, eventually developing the squamous cell carcinoma of the scrotum. Other problems, swelling of the scrotum could be caused by fluid, in which case it's called a hydrocele, blood, it's called hematocele. Lymphatic fluid accumulating in scrotum is called a chylocele. So take a look at the hydrocele, this is more common. It's just an accumulation of fluid in tunica vaginalis. Tunica vaginalis is a reflection of parietal peritoneum that goes through the anal canal and kind of lines the scrotum. The testicle sits in that little pouch. Sometimes fluid collects in that pouch, resulting in a swelling or enlargement of the scrotum. Here is again, another neonate with unilateral hydrocele, the scrotum. You can see, again, we got the normal side and we've got the swollen side here. Why it accumulates there? It depends. It could be some sort of infection, or sort of fluid accumulated as a result of infection. It could be a malignancy, or sometimes there's no apparent reasons, idiopathic. Hematocele also causes swelling like this, except it's caused by blood. You can guess just some sort of trauma. And then we got chylocele, lymphatic fluid, chylous fluid. It's kind of milky. That might be from a lymphatic obstruction. Any questions on that? Okay, so let's take a look at the testicle, pathologies that affect the testicle. First, we'll take a look at the microanatomy of the testicle, remind you of a few things relevant. That's a section through the testicle, stained with H&E, and of course you can see the testicle here. This whole thing is the testicle, and top of the testicle you have the epididymis, where sperm is generally temporarily stored for maturation. The testicle is encased in fibrous enclosure. This is called the tunica albuginea because it's white. Within the tunica albuginea, you can see the parenchyma of the testicle consisting of seminiferous tubules. There's also some interstitial cells that are of great importance, such as the Leydig cell that's responsible for producing the majority of androgens in the male. The seminiferous tubules are responsible for synthesizing sperm. The sperm are directed to these straight tubes called the ready testes. Thereafter, they're stored in the epididymis. Have a closer look. So here is a closer section of the testicular parenchyma, and of course you can see the tubules here. Those are the seminiferous tubules. There's the lumen, and you can see the tubules lined by two distinct types of cells. We're going to take a look at those a little bit more closely in a minute, but you got these larger cells, they're called Sertoli cells, and then you got these smaller cells, which are the spermatogonia in different stages of development. The Sertoli cells are not only the epithelial cells, but they also help support the metabolism of sperm. The sperm do not have enough genetic material to support themselves. They're haploid cells. Some of them are wide-bearing sperm. They don't even have a full complement of X chromosomal material that contains a lot of important genes for protein synthesis. They cannot support themselves fully, their own metabolism. So they have to have some of their metabolism supplemented by the Sertoli cells. Sertoli cells help support the spermatogonia. Because the Sertoli cells support the spermatogonia, they're sometimes referred to as nursing cells. So the Sertoli cells are sometimes called nursing cells. Within the interstitium, we have the Leydig cells. Again, those are androgen-producing cells. The seminiferous tubules are surrounded by these myoepithelial cells. These are part smooth muscle cells, part epithelial cells. They just help propel the sperm along the seminiferous tubules and eventually delivering them to the ready testes and then ultimately the epididymis. Let's have a closer look at this. There is a seminiferous tubule. Again, the lumen is very clear. You've got the epithelium here, and the tube itself is surrounded by these myoepithelial cells. You can see the spermatogonia, again, at different stages. And then you see these larger cells. There are the Sertoli cells. Those are the nursing cells. And okay, so any questions about normal histology? So let's take a look at some problems with the testicle. I mentioned this one before, it's called cryptorchidism. Cryptorchidism is a condition where the testicle does not descend into the scrotal sac. During embryogenesis, the testicle develops in the abdomen. But because of its unique physiology, it needs a cooler environment in order to operate properly. And so, the evolutionary solution was to take the testicle and put it into this external structure, this scrotum, where a lot of the heat can be dissipated, and the testicle's physiology can operate at a lower, more optimal temperature. The testicle is supposed to descend through the inguinal canal into the scrotal sac, generally by as long as up to a year postpartum. Usually it descends into the scrotal sac a lot earlier, usually a month or two prior to birth. The testicle will just descend into the scrotum. But it can descend into the scrotum up to a year postpartum and is still considered normal. If it does not descend after a year postpartum, that condition is called cryptorchidism. It's associated with several problems. Number one, for whatever reason, the testicle does not descend into the scrotal sac on its own. That testicle is associated with a higher incidence of testicular malignancy. The second problem, because the testicle is not in a cooler environment, it is being incubated in the core of the abdomen.
it eventually will become sterile. By the time puberty arrives, that testicle is not fertile. So if we discover cryptorchidism, generally speaking, if we're going to preserve the fertility of the testicle, we have to do something about it prior to puberty. Generally, if we discover that the testicle has not descended, we'll perform something called orchiopexy. We go up the inguinal canal, retrieve the testicle, and suture it into the scrotal sac. We do this to preserve the fertility of the testicle. Unfortunately, even if we perform an orchiopexy, the testicle still has more liability for developing a testicular malignancy. An orchiopexy doesn't change that. If we discover cryptorchidism after puberty, the testicle is not fertile and is only a cancer liability. And so we don't perform an orchiopexy after puberty, we would perform an orchiectomy. We remove the testicle. The testicle is useless, it's not fertile, and it's just a liability, so there's no rationale for leaving it in. So it's just removed. There are many reasons why a testicle may not descend properly. The testicle might be too big to negotiate the inguinal canal. Maybe the inguinal canal is strictured. Maybe there's not sufficient orchestration of hormones to get the testicle to descend. Whatever be the case, that testicle that does not descend has an increase in likelihood of developing a testicular malignancy. Okay, let's have a look at cryptorchidism. So here's an MRI of someone with cryptorchidism. You can see here we have thermal profile. We're looking at the left side here. You can see there's the spermatic cord there. You can see the testicle sitting in the scrotum. Everything's fine here on the left. On the right, it looks like this testicle is bigger. It didn't manage to get through the inguinal canal. And so here it's kind of stuck halfway through. If we catch that before puberty, we can just go up this way, pull it down, and suture it in position. If we get it after puberty, the testicle is worthless, not fertile, just poses a liability, we remove it. Yes?
If this only happens unilaterally, is it then just a decreased, like, fertility because the other one is still functional?
Yeah, the man will still have some fertility, it's just be reduced. And also, hormone production will probably be compensated. His testicle will probably enlarge because of the feedback loops that are constantly stimulated with gonadotropins, and it will respond to that. Gonadotropins are trophic, and so the testicle will compensate. Any questions on cryptorchidism? If we do perform an orchiopexy on this male to preserve the fertility of the testicle, remember, this does not reduce the malignant liability. And so people like this have to be instructed how to self-examine the testicle to assess for the development of possible development of cancer. They have to know what to look for. Okay, let's take a look at neoplasms of the testicle. And this is a type of cancer more common in Caucasians, affect 1 in 50,000 males. There are a variety of different types of testicular cancers, but if someone's been developed a cancer, it peaks within about 15 to 35 years. Some types of testicular malignancies actually develop later, but this is kind of the average range. It peaks in this range. Very young, 15, 35, still relatively young. It's kind of an unfortunate thing because in many instances there have been cases where a man just going to get married and discovers there's a testicular malignancy. Okay, two major types of neoplasms. You have the germ cell tumors, which are virtually all malignant. They're evolving from undifferentiated cells. Those are germ cells. Germ cells are undifferentiated. We say germ cells, we're talking about the sperm and spermatogonia, which are germ cells. And then we got the non-germ cell tumors, which are virtually evolved all from Sertoli cells and Leydig cells. Those are better differentiated. Those usually are all benign. The germ cell tumors, which again are virtually all malignant, most of those are subdivided to two categories, with seminomas and the non-seminomas. Let's first take a look at the seminomas. The seminomas are considered an older man's type of testicular malignancy. Usually, people older than the age of 40, somewhere between 40 and 50 typically will develop these seminomas. The word seminoma itself uses an incorrect nomenclature. The nomenclature used implies malignancy. Seminomas are not benign, they are malignant. They sometimes look deceptively well circumscribed, but they are still malignant. So here is an example of a seminoma. This is a serially sectioned testicle. It's been put in formalin. You can see the epididymis up here. There's the testicle. You can see the tunica albuginea, that white encapsulation. There's the testicular parenchyma here. And over here you can see this white mass. Again, deceptively well circumscribed. Some of these areas look very sharply delimited. Other areas look a little blurry. But again, you can see the degree to which the tumor is circumscribed kind of varies. Here's another deeper section, epididymis. You can see the tunica albuginea right there, and there is, of course, the seminoma right there. Some areas looking very blurry, that looks really suspicious. Over here, you've got a very well circumscribed area that looks almost benign. But again, this is malignant. The histology is pretty classic. This is the histology of seminoma. It consists of what are described as polygon-shaped cells. They kind of have part of their cytoplasm, part of their plasma membrane is kind of rectilinear, so they're called polygon-shaped cells. These are the cells here. They have a pore-staining cytoplasm. Okay. Nothing in here looks like normal testicle. But these are the classic cells, these polygon-shaped cells here that have those very pore-staining cytoplasm. Very often these cells, which are the malignant cells, are surrounded by lymphocytes. That's the classic presentation of a seminoma.
Dr. Mari,
Yes.
the polygonal cells are the same as the polygon cells that you're talking about? Is it the same thing?
The polygonal shaped cells, these are the cells. See, they kind of have straight borders, some of them. That's why they're called that.
Also, it's like
Polygonal.
and then, so what was the one you were saying?
I was mentioning that they're often accompanied by lymphocytic infiltrate. Okay. Again, this is an older man's type of cancer. 40 to 50 is generally the peak age. Other types of cancers usually develop in younger individuals. Here's an example of embryonal type cancers developing typically in men between 20 to 30 years of age. This is a bisected testicle. There's almost no normal testicle here at all. It's all been infiltrated with cancer. This cancer has a very hemorrhagic surface. Okay, maybe there's some normal testicle here, but all of this is cancer. It's infiltrated the entire testicle. This is the histology of embryonal cancer. Nothing really distinct about it. It's just sheets of poorly differentiated cells. That's all you can see here. No normal testicular parenchyma in there at all.
Dr. Maddie? So what would be, a complaint the patient could present with? If they have it?
We'll get to that, just a kind of a general presentation. All right, let's take a look at the different types of testicular tumors. So here's a chart showing you some important features of the tumor. The important thing for you to know about from this chart would be obviously the tumor name, know the peak age range. Okay, the histology is not important for you, you're not gonna be a pathologist. But the markers here, these would be something important you wanna know about. Okay? And I'll point out some things that make it a little easier to remember the markers, pretty logical. So I talked about the seminoma. Look, an old man's kind of cancer, 40 to 50 years. Okay, classically polygonal shaped cells and lymphocytes. Over here, the markers for seminomas really are unreliable. Most of the seminomas have no reliable markers whatsoever. 10% of them will make human chorionic gonadotropin. Okay, and that is because some of them have a kind of placental cell that develops what's called a syncytiotrophoblastic cell, which is right here. Syncytiotrophoblasts make human chorionic gonadotropin. About 10% of the seminomas have this syncytiotrophoblastic component to it. But generally speaking, the seminomas, 90% of the seminomas don't have any kind of reliable marker at all. Embryonal cancer, young man's cancer. 90% of them are either making human chorionic gonadotropin, again, that is made by syncytiotrophoblastic cells, or they're making alpha fetoprotein, okay, and that's from yolk sac tissue. Yolk sac tumor, yolk sac tissue, young. 100% of them make alpha fetoprotein, that comes from the yolk sac tissue. Choriocarcinoma, this is a type of cancer that consists of placental-like cells. And you remember from your anatomy, histology, the placenta consists of trophoblasts, two types of cells making up trophoblasts, the cytotrophoblast and the syncytiotrophoblasts. The syncytiotrophoblasts are the cells that make the human chorionic gonadotropin. And so 100% of these will make HCG. Teratomas. We talked about teratomas before. They evolve from germ cells, a type of germ cell tumor. They can differentiate into anything. Okay, so teratomas contain all kinds of cells, all ages can develop these. Half of them make human chorionic gonadotropin and or alpha fetoprotein. They can also make other things like thyroid hormones, sometimes they're called hyperthyroidism, thyrotoxicosis. And then we got the mixed tumor. Okay, younger persons, malignancy generally, you get 90% of them HCG and alpha fetoprotein. A couple things to remember. Again, it's the syncytiotrophoblasts that make HCG. So any one of these tumors that has syncytiotrophoblasts, you expect that part of the markers are going to be HCG. Alpha fetoprotein. The alpha fetoprotein that is made by yolk sac tissue. Okay, so anything that has yolk sac tissue in it will probably produce alpha fetoprotein. Okay, any questions on that? Let's take a look at the presentation. All these different tumors. The presentation, generally, the person will present with a complaint of maybe some sort of scrotal heaviness. So if the scrotum feels heavy, palpate the involved testicle, it will feel firm. Generally, it might be tender, but it won't be painful. When when the cancer's metastasized, you expect them to metastasize regionally, that's what they do, to the iliac or periaortic lymph nodes. And based on the person's age, you might have some suspicion about what type of cancer it is. You're probably gonna get markers like HCG, alpha fetoprotein, and based on those markers, the age, you can take a good guess at which one of these it's gonna be. You probably will follow it up with a needle biopsy, and if you can confirm that you've got a cancer there, the person's gonna have to have an orchiectomy. Okay, anything on that? Just to mention, we got the non-germ cell tumors. These are almost all benign. They're composed of Sertoli cell proliferations, leading cell proliferations. They can often secrete these steroids, either lots of androgens or lots of estrogens. And of course, those are gonna present with a number of different symptoms. Any questions on any of those tumors?
I do have a question. So, I don't know, you probably mentioned this, what is the difference between the non-seminomas versus the seminomas?
Non-seminomas. So, here are the seminomas. That's one category, and here are the non-seminomas.
Oh, okay.
It's either a seminoma or something else. That's the way we're looking at it. Okay. Any questions?